Hi nursing friends, this is Angie Gartner and
Bob Misfeld.
And we are coming to you today because we are going to go over how to administer respiratory medications. As we know, things could get crazy here with all these COVID patients, and we want to utilize staff the best we can. And our goal is, since we have limited respiratory staff, that they would be really in the areas of ED, ICU, PINS, all our critical patients. So we're asking you guys to maybe help us out and become therapists during this short period of time. Teamwork is dream work. So we're going to talk a little bit about how we do that, just to kind of give you guys all a refresher. Now this would only be utilized when the patient is not on a lot of oxygen, is not critical. So these would be your med-surg patients, or maybe those floating up to upstairs. It could also be your isolation patients or your COVID patients. We want to limit interactions with numerous staff. So if you're in the patient's room and they are short of breath and would need their inhaler, then you would know how to give that instead of calling RT, having somebody else come in and gown and all of that. Now, if that patient was on a ventilator or a BiPAP, or maybe he did high flow or something like that, then maybe it would be best to have the RT do it. We'll try to reassess that as we get more and more patients. So first of all, we're going to talk about nebulizers. Obviously, right now we want to give MDIs to our COVID patients, so we don't produce those aerosolized particles. But on med-surg or the other floor that doesn't have COVID patients, you can give aerosols. And so we want to go through that. And then Bob's going to go over inhalers with you guys. So first, just like anything, you'd want to go to your medication administration. You'd want to use your handy dandy little scanner, just like you guys do for your meds. And you'd pull it out of the Omnicell, and it's a foil packet, and you would scan the back of the foil packet. For practicing, we just have some saline that we're going to practice to show you, but main thing, you still want to scan the medication. So these are bronchodilators. They dilate the airway, so usually it's a duo neb, which is 2 drugs, albuterol and propionate bromide, and they're going to both help open up the lungs. Could be albuterol as well. So these are located in the respiratory closet. Some patients can do just the mouthpiece, and others need the mask. And so a lot of times we take both and ask them, or we just assess which one they can do. So you just open up the package. Comes in several pieces. You've got the neb cup, you've got the mouthpiece, you've got a little T. The T goes on here. The mouthpiece can only go one way. So, do you need a respiratory treatment, sir? So, it only goes one way. You have this little guy that's going to go on the end. Now, again, this is only non-COVID patients because we don't want this coming out into the air, right? And then you're going to get your tubing out as well. The blue piece we like to put on the end here, and then the other piece gets hooked to the flow meter, okay? We set our aerosols, the flow meter, about 8. If you want to put it anywhere from 6 to 8 will work. So then we take this little T-piece off. You're going to open up your foil packet. You're going to take your squirt of medication, and you're going to just squirt it in. And then you put the T-piece back on, and then you can turn the flow meter on, and you instruct the patient, sir, go ahead and put your mouth and teeth, everything on there, and take a nice slow breath in. And then maybe not point it at me. Okay. And then about every couple breaths, we have them take a bigger, deeper breath and really suck it in. And you should see this mist go away when they suck in, and you should see it come out. And then you know they're effectively getting it in. Now, if you didn't think they were doing well, they weren't taking a big breath in, or it's a dementia patient, or just they cannot understand what you're saying, now would be a good time to take it off. And you can also stop the drug like this so it's not wasted. And you would put a mask on. Sometimes you know this beforehand. If the RT maybe had this going for you or the previous nurse, then you would already know probably a mask treatment. And then you would have them put it on. Thank you, sir. And off we go. Now, we listen to breath sounds before treatment and after treatment. And so if you would like to chart that, that would be great. It's always great to see if the treatments help or anything like that. And then we'll figure out how you guys just chart the drug, and I'm not sure in your assessments if you know how to do that. But so you would do that. The treatment takes anywhere from 8 to 10 minutes. You'll notice the drug will start to kind of sputter at the end. We kind of give it a little shake, or maybe not on their face so it doesn't hit them, but if it's a mouthpiece, it's really easy because we kind of shake it and then give it back to them. So about 8-10 minutes till it's gone, and then take it off and do your assessments again.
When they're using the face mask, it does not matter whether they breathe through their mouth or nose. So if you see that they're breathing through their nose with the mask, that's perfectly fine. With the mouthpiece, it is not.
Great point. Okay, now we're going to move on to inhalers. And as you guys know, you see it in your MAR. A lot of them can have bronchodilators. A lot of them, we have some steroids. We have long-acting bronchodilators. We have all kinds of stuff. And so we're going to go over some of the main inhalers that your patient might have ordered, just so they are a little bit different in technique. And so I'm going to let my partner Bob take over for that.
Okay. We have basically two types of MDIs, metered dose inhalers and powdered inhalers. Metered dose inhalers can be taken with or without a spacer. We typically try and use a spacer with every treatment given here in the hospital. But at home, or if they bring it in, it very well may not have a spacer or come with a spacer. We're going to utilize a couple different types here in the hospital. One is a very fancy hard plastic spacer. Would you grab me that one over there? The other one is sort of an easy care makeshift spacer that works just as well. It just doesn't have a one-way valve as this one does. And these work with any metered dose inhalers, whether they are L-shaped or straight as this one is. It will not work with your powder inhalers that come in odd shapes like this or like this. And then there's also a round one, Advair, it's a purple disc. But if they come in an L-shaped or straight-shaped inhaler, like this, they need to be kept at room temperature. Sometimes they need to be given a shake, especially if it's the first time use or they have not used their own spacer. If they bring it in and it's been a month or more, you need to give it a shake, and you very well may need to prime the inhaler, if there's nothing in here anymore, by just pushing it down a couple of times until you can hear and see an actual mist. Now, with these L-shaped inhalers, they come out in one kind of quick little burst that the patient can generally feel. There is one that's a straight inhaler like this. This needs to be set.
That one's more of like an aerosolized type.
Right. So you set it by clicking. I'm not going to point it at you, James.
Great.
And you'll hear it click. And then this is set by a button. And you will see, I'm going to put it down here by my jacket. We'll do it this way so you can see a little bit. And you can see that mist, and it's a nice slower delivery. The patient is not required to have to inhale as forcefully with this one as the others. Now, whether you use the one-way valve or the soft tubing like this, they both will fit on like this. The patient gives it a shake, and they're going to put this end in their mouth, and they're going to press down, or you're going to help them press down, inhale at the same time. You want to take a nice, steady, easy, big breath, but it is not supposed to be a forced big breath. So it's just a nice, easy inhalation as you press down on the inhaler. The benefit of using a spacer is the medication is allowed to kind of sit in here if their timing isn't perfect. So if they start taking the breath after you press or before you press, there still should be medication in here that they can take. And you can always take a second breath without pressing just to make sure they get all the medication. Once they take that initial inhalation, they want to hold their breath for approximately 10 seconds 5 to 10 if they can't hold it for 10 seconds. And then exhale easily through either pursed lip or just a normal exhalation so that you're not pushing back out the medication that they just brought in. And then you'll wait a couple of minutes. It can be anywhere from just a couple of minutes up to 5 minutes, and take the second dose. And you're going to repeat that same technique where they take in a nice big deep breath as you press down, hold that breath in for 10 seconds, and then easily exhale. Now, once they're finished with the inhaler, you'll take it off, put the cap back on, put this away, and make sure that you chart that again with your scanner, just like you do with the nebulizers. After they've taken their medication, they need to either rinse or spit or swallow a fluid. And it can be water, it can be coffee, it can be juice. And water, they can typically spit it out, or if they want to swallow, they can swallow. But just rinse out their mouth so that the medication doesn't sit on any part of the palate.
Great job, Bob. A couple things I'd add. These are on back order, and so that is why you may have to use these. Works the same way, like Bob said. It keeps the medicine in there, but it also breaks down the big particle size. So better disposition. How do you say that, Bob? Disposition?
Deposition.
Thank you. So you get actually more medication with the spacers. So sometimes you'll get that patient that says, I don't want to use the spacer. But if you understand kind of the reasoning why, you can tell them we actually get more medicine because the particles can break down in size, and you'll get more of the medication. And a lot of times your patient will do that then. Another thing is this spacer has a built-in whistle, so that when the patient, like Bob said, takes the breath in, if they go too fast, you'll hear a whistle. So then you'll know, oh, you could tell them, that's a whistle, so that you want to take a nice slow breath in. You also get better medication. Say
Delivery,
again.
deposition.
Yes, if you do it that way. You can also, like we do in our kiddie world, kids, pediatric, you could put a mask on that. Same with an adult. And so we might have to do that down the road too. You would put that on their face. I have found, Bob, I don't know about you, if a lot of the times the patients are very familiar with taking these, so I don't have to sit and push it and do it for them. I usually assess how they do it. I ask them how long they've been doing their medications. If they have been doing it for years, I watch them do the first one. A lot of times I'll shake it and put it in here and hand it to them and let them do it. If I don't feel like they have maybe a good technique, or I could help educate that, then maybe I will stop, go through it, and so that the second breath goes better. We're lucky in RT because we have report and we can tell one another how they did and if they need assistance and all of that. And so we actually chart that in our MDI charting. But for you guys, maybe that would be part of your report or your communication, how they did with their inhalers, or if they are a patient that needs more assistance. So then each shift coming in.
Want me to show these other ones as well?
Yeah.
Okay. So we also have what we call dry powder inhalers.
Should I take one? Should I just take one?
Should take one? Sure. You can
Sure.
take one.
Okay.
So we have dry powder inhalers. You can hand me that.
Yeah.
That round one. They don't come in these particular colors, all of them, but they come in these. These are all, these two have the medication built inside them. And I'll show you how we get those set up. And then we have one that you have to place the medication inside, which is this one. And this, you have to open the lid, open this device, and you set a little tablet inside there, shut the device, and then you puncture a hole in that tablet by pressing this. There's just one tablet, and you just push it one time. There's no medication released with this unless the patient inhales on the mouthpiece. Did you want to do this? Okay.
Sure.
So all you have to do is prep the medication. And again, they typically do this at home, so they can help you with it as well. But you make sure the medication is in there. And the medication for these comes in like a little punch bag where their tablets are multiple in a thing, and you'd have to scan.
So this would be like your Spiriva.
Correct. And then they just draw in. I'll let Angie draw in. She's
So
closer to the
sometimes
camera.
I'll have patients that want to click, 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 and we only want them to click one time because they can break those little particles from the capsule and they can actually inhale that. And so just one click, and I get real nervous if I see them do it more than that. So I try to really tell them that before. And then you should hear like a little noise,
A little shaking
a little
of that
shaking
tablet.
when the patient draws in. So then I just have them put it in their mouth and take a big breath in.
And the technique's the same. You draw it in and they hold their breath for approximately 10 seconds. And they can draw in once or twice if they want to make sure they get absolutely every bit of the powder. As long as there's not a new tablet in there, they can't get more than they're expected
So
to.
then you would just dump out the capsule, and a lot of times the patients want to see it, and there is a little hole, they'll see that, but then you want to toss it. We actually even had one patient swallow the pills, and she didn't know what this thing was, and she was swallowing the pill. So it can happen, but that's why we want to dispose of it right after we administer it. So that is Spiriva.
All right, and then there's a couple others that come in a Lipton. Now this is an older one. It's not this shape anymore, but they're all still very similar. And they set either by themselves, just by opening them, you'll hear a click, and that'll set, or on some of them, you need to prep it by pulling this down, and you'll also hear a click. And that means that little tablet again, or little, in this case, it's just a little container piece, is open and it's ready to inhale. And the technique for these now is the same as the one we just showed you. They take in a nice big breath on the container, hold it in for 10 seconds, and then blow it out. And again, they can take 1 or 2 breaths to get all the medication from that one puncture out. And they still rinse and spit or rinse and swallow with these devices. You bet.
So he basically loaded it. It's like a gun. You loaded the bullet. You don't want to tip this because it's a powder and you don't want to tip it. So you load it, you be very careful and say, you know, it's loaded, ready to go. If you have that patient that does it, you just don't want them to tip it. And like Bob said, then you still have them take a breath in. And a lot of these are very important to rinse your mouth afterwards. Especially corticosteroids. We all know that patient can get thrush in their mouth, and so that is the main reason why we have them rinse and spit. They can swallow, but some people can get an upset stomach from that medication.
Some of them have counters on them as well, so that you can see this one has a number counter, and it will tell you that you just took it, so it'll go from 14 to 13. It usually tells you how many you have left in the container. And the same as on this one, it has a little counter window here. Some of them have a little counter that's on the top. This one's fake, it doesn't move, but it has a counter on the top.
And those are good too. So when you see you only have a couple doses left and you know that patient isn't being dismissed anytime soon, because these are hospital ones, so we have less than what the person would have, you know, if they'd go pick up a prescription at their local pharmacy. So we have less doses here. And so definitely watch those counters, because you want to inform for a med request, then you put in a med request for pharmacy that we only have 2 more doses left or whatever. You'll have to watch the order. Again, your bronchodilators, some of them are every 4 hours PRN, some are 6, some are actually scheduled. Some of these drugs are only once a day or twice a day. They're not rescue inhalers, they're more for maintenance. And so you definitely, if you need help knowing which drugs are maintenance and which drugs they can have more often, and that's probably the biggest thing, because you don't want to give a maintenance drug that's 1 or twice a day and mistakenly take that for a rescue drug when they're having shortness of breath or wheezing. And so if you need help with that, just call us and we'll help you, and maybe we can figure out
friendly respiratory therapy.
Yeah, and maybe we'll figure out, maybe we can have a sign or something to help you guys as well. Bob, any other lasting thoughts?
I think that was pretty quick rundown. Again, if you have any questions, don't hesitate to call. Thank you for your attention.
Yes, you guys got this. We believe in you, and we're gonna get through this together. At the end of the day, they're definitely gonna know how important our T and RNs are. So we love you guys. Bye.